a 16-year-old boy with long-standing history of anemia. He has significant prolonged neonatal jaundice and multiple episodes of jaundice without fever. He is at 50th percentile of height and weight and denies any neurological or gastrointestinal symptoms. Physical examination reveals generalized pallor, scleral icterus, and splenomegaly. His hemoglobin is 10.2, and peripheral blood smear shows RBC basophilic stippling. Which of the following is most likely diagnosis? Pyruvate kinase deficiency, cytochrome B5 reductase deficiency, lead poisoning, pyrimidine 5 nucleotidase deficiency, and G6PD deficiency. Okay, so let us first establish what facts do we know. So this patient is having anemia. He has prolonged neonatal jaundice. Okay, first of all, like the jaundice has been since the child was born. Like it's there forever. It is nothing that is. It is not new. It is not acute, and there was no fever. There was no fever during childhood. It is just jaundice. Okay, there is some developmental issue as well, and there is no neurological or gastrointestinal symptoms. Okay, there is general pallor, scleral icterus, splenomegaly. Okay, so along with jaundice, there is pallor. So this child has jaundice plus pallor plus splenomegaly, and there is basophilic stippling. Okay. Now, what I will first of all think is this patient is having jaundice plus anemia, which means that there's a higher possibility that there is some kind of hemolysis, and because of that, the jaundice is there. Because there is jaundice plus anemia. Basically, what I'm trying to say is that this doesn't seem to be an obstructive jaundice. This doesn't seem to be an obstructive jaundice because obstructive jaundice does not have any reason to present with anemia. It does not have anemia. This seems like this patient's RBC are affected in some way, which is leading to hemolysis, which is leading to jaundice as well as anemia. Okay, and splenomegaly is there, which is fine. Splenomegaly can occur in any kind of chronic hemolytic disease. Okay, now we have to choose between these options. So is this pyruvate kinase deficiency? Is this cytochrome B5 reductase? Is it lead poisoning? Is it G6PD, or is this pyrimidine 5 nucleotidase deficiency? Now I know that pyrimidine 5 nucleotidase deficiency, this enzyme is involved in some kind of nucleotide, either RNA or DNA formation, because it is a nucleotidase enzyme. The enzyme itself tells me that it has something to do with RNA and DNA. Now RBC is having basophilic stippling. Basophilic stippling indicates, if you know, presence of ribosomal or RNA residues in the red blood cell. Okay, ribosomal or RNA residuals in the red blood cell. Now all of us know that lead poisoning leads to basophilic stippling. That is a common fact. Okay, and from these options I can guess that this deficiency may also lead to basophilic stippling. G6PD does not lead to basophilic stippling. It has those bite cells and Heinz body. Cytochrome B5 reductase deficiency. This seems to be like some mitochondrial enzyme. I don't think so. It has anything to do with RNA, DNA, or ribosomal residue. And pyruvate kinase deficiency. I know about this deficiency. This deficiency affects the cell membrane. It has again nothing to do with RNA, DNA, or anything. So I have two possibilities. Either it can be lead poisoning that I know leads to basophilic stippling, or it can be pyrimidine 5 nucleotidase deficiency that I know that I guess can lead to this deficiency. Now, there are multiple places where they have tried to indicate that this is not lead poisoning. Lead poisoning leads to neurological and GI symptoms as well. Lead poisoning needs exposure of lead, which this patient did not have time to, because he had this problem since he was born. So this makes my claim towards lead poisoning lower, and I would go with the option of pyrimidine nucleotide deficiency, even if I didn't know that, even if I haven't read about that I will go with pyrimidine nucleotide deficiency. Then that is our right answer. Now, just to give you some details about this disease, so that if it comes up sometimes, you will know. So it is third most common RBC enzyme defect. The first is G6PD, second is pyruvate kinase. So basophilic stippling of RBC is due to precipitation of RNA that has not been degraded and is typically suggestive feature of this condition. Okay. Yes, so, and then they have given some examples where basophilic stippling is seen. So we all know lead poisoning, beta thalassemia, and sideroblastic anemia. So these are the cases where basophilic stippling is seen along with pyrimidine nucleotidase deficiency.
Thanks for watching. Please give a thumbs up and subscribe for more.